Oh, hi! So you clicked on this video because you want to learn something related to dentistry. Well, you are on the right place. I am Dr. Hina, the voice and soul behind Dr. Teeth, and this is the platform where we make learning interesting and incredibly easy for you. So do leave a like and subscribe to my channel, and I will recommend you to join channel membership to watch our premium videos. You can also visit our website for online classes, courses, MCQs. So let's get started. Hello everyone, Assalamu alaikum. Welcome back to Dr. Teeth. Today we are going to learn about bruxism and prosthetic treatment. So this is going to be a very seminar-like video where we will be discussing about the definition, etiology, types, management, and many more things. So stick to the video till the end because it's going to be really interesting. So without further ado, let's get into the video. And if you are new to this channel, please do consider subscribing because it really motivates me to create more videos of this kind. And also, if you like the video, do comment and let me know because that really makes my day. So let's get started. Now the first question is, what is bruxism? So simply put, I will leave all this definition and I'll come to this. Other than chewing movement of the mandible. So any movement that you are making that is other than the chewing movement, okay, and it comes in the parafunctional movement, means it is not a specific function, like it's not related to mastication, it's not related to speech, it is something else, like it is not the function that we really need to do, okay. So bruxism is defined as a parafunctional grinding of the teeth or an oral habit consisting of involuntary, rhythmic or spasmodic, non-functional gnashing, grinding or clenching of teeth in other than chewing movement of the mandible, which may lead to occlusal trauma. So see, chewing movement is necessary, like we have to do it, and in that movement we have the food in between the teeth, right? So we are not actually putting a lot of pressure on the teeth, okay? But in bruxism, what we are doing something which is not required. We are doing a parafunctional habit. We are doing a parafunctional grinding of the teeth, okay? So it is grinding, clenching of the teeth, and we do it involuntary, like we have no idea about it, or sometimes it can be like you are aware of it, like when you get to know about it. So it can be voluntary also in that cases. So that is bruxism. Let's talk about the types of bruxism. Now, bruxism can be of two types, awake bruxism and sleep bruxism. As the name says, like awake bruxism, the person is aware of this habit, as I told you. He is aware of the habit and often self-reports it, means the patient will come to you and he will tell you that I have this habit and because of that, I have the problem, like my teeth are grinding off, they're getting shorter, I have sensitivity and various other problems. We'll see in the clinical features, okay? And sleep bruxism is the bruxism during sleep, either during daytime or during the nighttime. So there are two types of bruxism, awake, also called as diurnal bruxism, and the sleep bruxism. Let's talk about the prevalence rate. Now, this awake bruxism, it occurs around 20% of the population, and the sleep bruxism occurs in about 8 to 16% of the population. Okay, so thing with sleep bruxism is that it onsets like about 1 year of age soon after the eruption of deciduous incisor, and it appears very frequently in the younger population. So if we talk about the children, the prevalence will be like 14 to 20% in children, okay? But in adults above 60 years of age, you will only find very less chances, like only 3% are being aware of frequent grinding. So that's about the prevalence. Let's move on. Now, etiology. What could be the cause of bruxism? उसका दिमाग तो खराब नहीं होगा ना कि वो कुछ भी ऐसे ही चबाता रहेगा. I mean, something might be wrong with him, right? So what is the etiology? So various like theories have been put कि इस वजह से हो सकता है, उस वजह से हो सकता है, लेकिन किस वजह से हो रहा है ये किसी को नहीं पता है, ठीक है? So I'm sorry, I'm talking in Hindi in between, but I'll stick to English. See, etiology Many people say that it could be peripheral factor, means teeth related factor. We'll see this in detail. And psychosocial influences, stress and depression and all those things. And then central or pathophysiological. Now let's talk about the first one, that is the peripheral factor. Okay, now we say that the teeth should be in harmony. The upper arch should be in harmony with the lower arch. That is true. That is absolutely true. But no matter how many studies we have done in the past, several studies have agreed that there is no or hardly any relationship between clinically established bruxism and occlusal factors in adult. So this does not seem to be very convincing, like it could be peripheral factors. You cannot say that because studies have said otherwise. But what about the psychosocial factor? So a multifactorial large-scale population study to sleep bruxism revealed highly stressful life as a significant risk factor. So even though it is a risk factor, depression, stress, it is a risk factor for bruxism. Like out of depression, he could be grinding, clenching his teeth. But all these studies are still not conclusive. We cannot come to a conclusion like this is the cause. So let's discard it. Then we have the central or pathophysiological. Okay, so here they say that bruxism has been shown to be a part of arousal response. Now what is an arousal response? It is a sudden change in the depth of the sleep during which the individual either arrives in the lighter sleep stage or actually wakes up. Okay, so what is the arousal response? It is a sudden change in the depth of sleep. Like during sleep, like there is sudden change in the depth of the sleep during which the individual will either arrive in the lighter sleep stage or actually wakes up. So that is arousal response, and bruxism has been shown to be a part of this response. But such a response is accompanied by gross body movement, increased heart rate, respiratory. So here they are telling about, arousal response in little more detail, like what happens in that. Like the body will be having some gross movement, there will be increased heart rate. Basically, you're having a lighter sleep and all these accompanied with that. Okay. More to it, bruxism may be related to disturbances in the central neurotransmitter system. It is hypothesized that the direct and indirect pathways of basal ganglion, a group of 5 subcortical nuclei that are involved in the coordination of movement, is disturbed in a bruxa. So people have hypothesized that the direct and indirect pathways of the basal ganglion, a group of 5 subcortical nuclei that are involved in the coordination of movement, it is disturbed in bruxers. So there they have the problem. Okay. Now this is also hypothesized. Nothing is sure about it. Now acute use of dopamine precursors like L-dopa inhibits bruxism activity, and chronic long-term use of L-dopa result in increased bruxism activity. Now I'm just going through this like I'm reading this. Don't tell me in the comment section that ma'am you're just reading it. Obviously I'll be reading it because there is nothing more to tell about it, right? It's very self-explanatory. Okay. Now, so in the previous slides we have seen that the etiology is multifactorial. We cannot say that only one specific etiology is a cause. There are many etiology. There could be many etiology, and none of them is a short one. Okay. Now, but we are sure that it is not caused by occlusal disturbances. It is not caused by morphology of the teeth, the first one, right? And it is not caused by incorrectly prosthetically modified occlusion. But the things about which we can say something surely is the risk factor. Risk factor include lower age, okay, female gender, more in female. I forgot to tell you in the prevalence that it is more in the female. So female gender, tobacco, alcohol and caffeine usage, psychosocial factor, sleeping disorders, okay, like obstructive sleep apnea. I want to take a video on this, and genetics and certain medications or drugs. So these are the risk factors. You can just note it down if you want, or you can again come back to this channel to watch it. Okay. Okay. Now let's talk about the symptoms of bruxism. Now anxiety, stress, tension, depression, earache, eating disorders, headache, hot, cold or sweet sensitivity in the teeth, insomnia, Why this will happen? Because the patient has atresion, okay, and insomnia and sore or painful jaw. Obviously, if you're applying so much pressure, you're continuously using your jaw to clench and grind, that will happen. Let's talk about the clinical features. The first one is occlusal trauma. So they can be occlusal trauma because of continuous grinding, and it can result in mobility more in the morning, because in the patient who have night bruxism habit, the entire night they will be doing this. They will be grinding, clenching, and in the morning they will have pain and they will have no idea why they are having pain. Then tooth structure. So it results in non-functional occlusal wear, sensitivity, atypical shiny wear facet with sharp edges, pulpal exposure. Then muscular tenderness, obviously because your muscles are overactive, they are put to more work. So lateral pterygoid, masseter on palpation, fatigue on waking up, hypertrophy of masseter. So these things you'll be able to notice. And then TMJ disturbances, crepitation, clicking, restriction of the mandible movement, deviation of chin, and pain which will be dull and unilateral. So like, it's still not proven that bruxism is a causative factor for tooth wear or even for TMJ. I mean temporomandibular disorder. It's still not fully known according to the articles I have gone by. If you have any more details on this, feel free to comment below and I'll check that article out. More clinical features, headache, okay, and other signs and symptoms like sounds, grinding, tapping, soft tissue trauma, small ulceration or ridging on the buccal mucosa opposite the molar teeth, and various problems with dental restorations as well as with fixed and removable prostheses. Now this is interesting. Like we always talk about attrition of the natural teeth in bruxism, but what if such patient comes to you, like you're not aware that the patient has this habit, or even if you're aware that the patient is a bruxer, and you give the patient some prosthesis, whether fixed prosthesis, removable prosthesis, what will happen? He will come back to you after some weeks, some month, or earlier than expected with a broken restoration, a restoration that is worn off. So that is an additional problem with the bruxer. Even their restorations can fail earlier. Okay. Now coming to the diagnosis, how will you know that the patient has this problem? Very simple thing is that ask the patient, that is questionnaires. Now the problem or the disadvantage of this method is the information obtained is subjective in nature. The patient might tell you, might not tell you, or the patient might be aware or might not be aware of it. So how will he tell you? And it has been found that about 80% of bruxism episodes are not accompanied by noise. So the patients might fail to identify themselves as bruxers. So if in 80% of cases the patient themselves are not sure if they have bruxism, how will they tell you? So this is not a good method. But nevertheless, you can start with this, asking the patient. Now in clinical examination of such a patient, you will be able to see tooth wear within normal range of jaw movement, and there could be hypertrophy in the masseter muscle on voluntary contraction. The patient can complain that he has little tenderness or discomfort in the masticatory muscles, okay. Fatigue, stiffness in the morning, especially if the patient is a night bruxer, and the teeth might be hypersensitive to cold air liquid, and even the TMJ can have clicking, locking sound, and there could be indentation on the tongue or the cheeks. So that comes in the clinical examination. Also, the partner of the patient will be a very important person in diagnosis. The partner of the patient has more chances of knowing it because they might get disturbed by that sound in the night, okay. Now we have intraoral appliances. This can also be used to diagnose it. How? See, first of all, there are two ways with the help of this appliance. First of all, we can observe the wear facets of the intraoral appliance. Like you gave an appliance to the patient and ask the patient to wear it. If the patient will be a bruxer, you will observe wear facets on the appliance. Then measurement of bite force loaded on the intraoral appliance. You can measure the bite force, like whether the patient is biting too hard. So you can have an idea if he is a bruxer. Now comes a very important question. Can bruxism be treated? And the answer is unfortunate, but it is the answer that no specific treatment exists. But nevertheless, the awake bruxism may be eliminated by habit awareness, habit reversal therapy, relaxation techniques, and biofeedback massage therapy. But still, we don't have strong evidence that any of them is effective in the treatment of bruxism. But still, we can try. We can make the patient aware that you have the habit and it's better to avoid it or stop it so that you can save your precious teeth. Okay, relaxation, biofeedback. I'm sorry, this is massed therapy, not massage therapy. So basically, you might have learned about this in the periodontics. Okay, if you haven't, I already have a video on this on my channel, so you can check that out. Now let's talk about the management of bruxism, the strategies to reduce the deleterious effect. We know that we cannot treat it, but we can manage it. So by managing, we can reduce the deleterious effect. First of all, we can have occlusal appliances. We can give various type of splints to the patient. Most of them are hard acrylic resin stabilization appliances, mostly worn in the upper jaw, and we prefer the hard splint over the soft splint for practical reason. Like soft splint are more difficult to adjust than the hard ones to prevent inadvertent tooth movements, and also because hard splints are suggested to be more effective in reducing bruxism activity than the soft splint. So this was about the occlusal appliances. So we can give occlusal splint night guard to the patient. Let's talk about interocclusal appliances and TMD. Now in the clinics, there could be times when you have a patient who complains of clicking sound, and you might have advised him interocclusal appliances. You might have advised him splint, or your teacher might have asked you to make a splint for him. So does it really help? So recent reviews have concluded that interocclusal appliances do not offer a definitive or curative treatment of bruxism or the signs and symptoms of TMD. Similarly, their efficacy in reducing nocturnal muscle activity and craniofacial pain is unclear. So even though we are giving it, it is unclear whether they really have curative effect on the TMD, temporomandibular disorders, or even in reducing the muscle activity, craniofacial pain. Then we have the biofeedback. Biofeedback is based on the principle that bruxer can unlearn their behavior when a stimulus makes them aware of their adverse jaw muscle activities. That is the aversive conditioning. This technique has been applied for bruxism during wakefulness as well as for sleep bruxism. You might have read about this in periodontics. So while awake, the patients can be trained to control their jaw muscle activities through auditory or visual feedback from a surface EMG. For sleep bruxism, auditory, electrical, vibratory, and even taste stimuli can be used for feedback. Let's talk about the pharmacological approach. Drugs that have paralytic effects on the muscles through an inhibition of acetylcholine release at the neuromuscular junction decreases bruxism activity, especially in severe cases with comorbidities like coma, brain injury, amphetamine abuse, Huntington disease, and autism. So we can give ethyl chloride for pain, local anesthetics like for TMJ, okay, and tranquilizers, sedatives, muscle relaxant, diazepam for anxiety and alteration of sleep arousal, and tricyclic antidepressants. Now let's talk about the effect of bruxism on prosthetic reconstruction. How does it affect our prosthesis? That's an interesting topic. So first of all, let's talk about the effect of bruxism on prosthetic restorations on natural teeth. So we all know that loss of retention and fracture of material, they are the two most common causes of failure of the FPD. In addition to that, we have biological failure like caries, marginal degradation, and endodontic problems are also of concern. So for a bruxer, these problems are still more exaggerated. So problems with prosthetic restorations being provided for a worn dentition. Okay, first of all, mechanical retention and resistance form is not available because the teeth are already worn out and very short. How will you get mechanical retention? And then there will be increased chances of mechanical failure. Now, there are certain materials which are recommended for used in FPD fabrication in patients with bruxism. So, when we have an opposing natural teeth, most clinicians and researchers, they agree that metal occlusal surface and preferably one with high noble content is preferred. So metal ceramic restorations seem to be the safest choice in cases of high load conditions. Gold acrylic FPDs for heavy bruxers, as it has less risk of chipping off unlike the ceramic veneers, and improvement of the veneering system is specially required. And then unpolished ceramic should be avoided because it can really harm the opposing natural teeth. Let's talk about the biomechanical factors, the design factors, what we need to consider in such patients. So single crown should be constructed whenever possible, and FPDs should be of minimal extension. You cannot make long span FPDs. In short worn abutments, we can include boxes and grooves or parallel pins. Splinting should be avoided wherever possible because the rich sensory information provided by the periodontal mechanoreceptors of unsplinted teeth is preserved. So here we can see that in short worn abutment, we can include boxes, grooves or parallel pins. This is a groove, okay? Effects of bruxism on implant restorations. So these are the various studies. So in a prospective 15-year follow-up study of mandibular implant-supported fixed prosthesis, smoking and poor oral hygiene had a significant influence on the bone loss, while occlusal lowering factors such as bruxism, maximal bite force and length of cantilevers were of minor importance. So we can see that in this study, this was a 15-year follow-up study, it was found that occlusal lowering factors such as bruxism or maximal bite force and length of cantilevers were of minor importance. Systematic reviews have concluded that a causative relationship between occlusal factors and loss of osseointegration has never been demonstrated. So that's about it. Like occlusal forces and osseointegration, they don't affect each other. Thus, implant restorations may fail due to load increasing factors, poorly planned occlusion, or inadequate mechanical design at the reconstructions, rather than to bruxism per se. So bruxism does not seem to affect the success of implant restorations. Talking about the effect on the complete denture. So bruxism is a frequent cause of complaint of soreness of the denture bearing mucosa. Obviously, the patient has a habit of biting hard, so mucosa might become sore, and it could be a possible factor related to magnitude of ridge reduction. Obviously, it can increase the magnitude of ridge reduction. Coming to the effects of bruxism on the removable dental prosthesis. So this you can read in the article. I will leave the link to the article in the description box below. Okay. So here I would like to just mention that heavy bruxism may have detrimental effects on the residual dentition and the denture bearing tissues in patients with RPDs, although this has not been systematically studied. So we can say that there is no evidence that prosthetic therapy or any other available treatment can eliminate bruxism. Eliminating bruxism is not really possible as of today. And also there is no such evidence that bruxism can be caused by prosthetic therapy. Okay. Even though we cannot eliminate this problem completely, we can still manage it. We had seen in the slides which went by that it can be managed. And with this review article, we got to know that the effect of bruxism on various prosthetic restorations, it is an area that needs further attention. It needs further research from our side. And we also saw that even though we don't have a strong evidence for the benefit of interocclusal appliances, it is still the commonest and most accepted way to prevent the tooth wear So with this, I would like to conclude today's video. I hope you found the video helpful. I would suggest you to go and read the full article. It was a very interesting article, so I thought why not make a video on it and share with you all. If you like me to discuss more such articles, do let me know in the comment section below because I really love to hear from you guys. I'll see you in the next video. Take care. Allah Hafiz.